substance misuse comorbidity, and other comorbidities. So why does this really matter? Diagnosis is critical for planning treatment. Major depressive disorder is currently defined by absence of hypomania. Lifelong risk of conversion to bipolar disorder, annual conversion rates of 1% for bipolar 1 disorder and 0.5% for bipolar 2 disorder. So from unipolar depression to bipolar 2 and unipolar depression to bipolar 1. Earlier bipolar diagnosis should greatly improve prognosis. At the end of the day, we got to get the diagnosis right. If you treat somebody with bipolar as major depressive disorder, that's going to lead to problems, right? So getting the diagnosis right will guide the prognosis. In the past, they used to say, diagnosis is prognosis. If you don't get the diagnosis right, you're not going to be able to predict the future. It is also important for research purposes that are listed here. And of course, antidepressants for bipolar depression is one of the most controversial areas in the history of psychiatry in terms of treatments for psychiatry, clinical therapeutics. Are they effective in bipolar depression? Are they ineffective? Are they safe or are they dangerous? Is something I'll answer later on. So in terms of what I'd like to put it to you, you want to know the bottom line. You got to get the balance between diagnostic conservatism and uncritical over-inclusiveness, diagnosing people with borderline personality disorders or ADHD as bipolar disorder doesn't help anybody. So you got to get the balance between the diagnostic conservatism versus uncritical over-inclusiveness. I'd like to share with you today 3 groups of patients as bipolar spectrum. Depressed patients who have experienced hypomania soon after taking antidepressants. Depressed patients with a history of subthreshold manic symptoms which fall well below the DSM-4 diagnostic criteria, threshold for hypomania. Depressed patients who have never experienced manic symptoms but who have several other indicators of bipolarity. Somebody at the end of my depression masterclass asked a question. I told them I will answer this today, and here they are. These are the indicators of bipolarity. First degree relatives with bipolar disorder we spoke about earlier. Early onset depression, high recurrence rates, atypical depressive symptoms, reversal of neurovegetative symptoms, oversleeping, overeating patients, hypersomnic, hyperphagic patients, depressive mixed states, which we'll return to, high comorbidities, psychotic symptoms are indicative of possible bipolar illness. Postpartum onset may indicate bipolar depression, and seasonal presentations. Winter depressions is commoner in people with bipolar illnesses. So if you go by narrow diagnostic criteria, it's about 1%, but there's a gray area of bipolarity here compared to the 1% we speak about. Here we have lifetime prevalence rates of bipolar disorders using strict DSM-5 or DSM-4 criteria. The prevalence is about 1%, 1.5%. But if you use the spectrum concept, that can rise from 5 to 8%. A conservative estimate, 1% of the population, 10 to 15% of all affective disorders. These are some famous people with bipolar disorders. Mine hasn't got onto the slide yet. If you don't find yours, I apologize for it. And if you look at Ron Schumann, the famous composer, if you look at it, Ron Schumann's ability to compose music, they were high amongst hypomania, right? So not that you want to become hypomanic to become productive. I'm just showing you the course or in some patients, some people, famous people. This is Mozart. And this is what Mozart said, make what you will. When I am completely myself, entirely alone, of good cheer, my ideas flow best and most abundantly. And how they come, I know not, nor can I force them. Flight of ideas. Lord Tennyson, the English poet, experienced debilitating depression and hypomanic spells. Again, see this poem. Half a league, half a league, half a league onward, into the depth of valley rode the 600. Forward the light brigade, charge for the guns, he said. Into the valley of death rode the 600. And K. Jamieson, of many senior psychiatrists will know Jamieson and Fred Goodwin's monograph that was published in 1990 called Manic Depressive Illness. She suffers from bipolar herself. And this is what she said. I've often asked myself whether given the choice I'd choose to have manic depressive illness. Strangely enough, I think I would choose to have it it is complicated. Depression is awful beyond words or sounds or images, but normal or manic have run faster, thought faster, and loved faster than most I know. And I think much of this is related to my illness. The intensity it gives to things. Of course, she had treatment and positively dealt with it. If you look at the mood instability of Tennyson's, Alfred Tennyson, the poet, is here. Look at the strong family history in this family, right? Two brothers, Arthur and Septimus, had unipolar depression. Two sisters had unipolar depression. Brother Edward had bipolar disorder. Brothers Charles and Frederick had mood instability. Father George had bipolar disorder, and his two sisters had unipolar depression. This is a rare family with a lot of history of genetics. So heritability, bipolar disorder is a complex and a multifactorial, multipolygenic disorder. The heritability of bipolar disorder, based on concordance rates for bipolar disorder in twin studies, has been estimated between 60 to 80%. Slightly low estimates of genetic risk have been suggested based on family studies and larger population cohorts. In clinical practice, positive family history is not that common. This is not a monogenic Mendelian disorder. This is a multifactorial polygenic disease. The genetic testing will be of little clinical utility and not done in many countries. Bipolar 1 in genetically is closer to schizophrenia, and bipolar 2 genetically is closer to depression. There are common variants as risk factors for bipolar disorders. These are listed here. These are all single nucleotide polymorphisms. By the way, I will be going fast at times. I'm assuming a lot of knowledge amongst senior psychiatrists, junior psychiatrists, and postgraduate trainees. All of the slides will be available in a PDF format and will be sent to Professor Shahan Williams for you to go through at leisure. So, chromosome disorders with mood symptoms, Professor Kure and others who are learning disability consultants like Dr. Manju Bhashini, who has joined us, will know these patients. Prader-Willi syndrome, various division syndromes, viliofacial syndrome. They are all related to mood disorders, including bipolar disorders. There are some monogenic disorders with symptoms of bipolar disorders, like Smith-Magenis syndrome with typical facial characteristics, learning disability, and mood disorder. In terms of distribution by sex is equal overall. Most males start their careers with a manic episode. Female predominance amongst patients with rapid cycling, bipolar 2, dysphoric mania, mixed states, and depressive episodes. Subtypes, mixed states, there's female preponderance. First episode can happen late in life. It's not uncommon for old age psychiatrists to see a patient presenting with a mixed affective state for the first time. We of course exclude organicity. We do CT scans and MRIs. Early episodes tend to be depressive mixed states, higher rates of suicide and comorbidity, and great association with organicity and worsening with antidepressants. One of the clinical points you need to take here is if you diagnose mixed states, you must avoid antidepressants like plague. It's better to treat with mood stabilizers like valproate, query lithium. Lithium is said to be less effective in mixed affective states, and or antipsychotics. Lorazepam has good data. Alan Swan from Texas did an analysis recently to show patients with irritability as a symptom, along with depression, did better than patients without irritability in mixed states. Mixed states have been operationalized stable and static construct by classificatory systems. In reality, in clinical practice, whether it is in Colombo, Jaffna, Batticaloa, or Trincomalee, they are complex, fluctuating, and unstable clinical pictures. They may be better defined along a continuum or a spectrum of mixity: pure depression, agitated depression, depressive mixed states, dysphoric mania, and pure mania. And this is the old Kraepelinian concept. Kraepelin saw 60% of the patients as in between states: agitated depression, depressive mixed states, and dysphoric mania. Dysphoric mania is a traditional conceptualization of mixed states. Mood intrudes, depressive or dysphoric mood intrudes into dominant mania. Agitated depression is the converse mix, presence of manic features in a dominantly depressive presentation. When you have psychomotor agitation, when you have psychomotor activation, these patients are more bipolar than depression. Why are they activated? Why are they agitated if they are depressed? Is the question you need to ask yourself. And some people believe some of the so-called treatment-resistant depressions are resistant because they're bipolar patients and not unipolar patients. So I've already made the point here. The three symptoms to look out for, these are the commonest in factor analysis studies: flight of ideas, distractibility, and irritability as comorbidities in depression in particular. Treatment studies of mixed affective states. Most studies are designed to treat pure manic episodes, not mixed episodes specifically. Patients with mixed states are usually a small subset of a total number of patients studied. Even double-blind placebo-controlled studies have to be interpreted with caution. Maintenance treatment studies are limited. They're coming thick and fast now, but they were limited 10 years ago. Rapid cycling disorder is a concept introduced by Dana and Feeve in 1974. To be called, it's a cause specifier in DSM-4 and 5, defined as 4 episodes of illness per year. There must be 2 months period of partial or complete remission between episodes, or switch from one pole to another. If you are treating a patient with depression, they switch into hypomania, they are counted as 2 episodes. If you're treating a patient with depression, there must be partial or full remission before the next episode for the second episode to be counted. Prevalence is about 13 to 20%. At the end of the day, it is about rapid cycling depression. Depression is the major burden. But of course, you'll see some patients with rapid cycling hypomania. They're not that uncommon, particularly in learning disability patients, some ultra-rapid cyclers. Disputes as to whether it is more common in bipolar 1 or bipolar 2 disorder. Normally, I ask the audience. Today, you are lucky thanks to COVID. I'm asking the questions and answering it myself. It is commoner in bipolar 2. Why? Even though bipolar 1 patients have the higher propensity to cycle, the durational criterion will not be met. That's the problem, right? So if a patient with bipolar 1 depression, they'll spend 3 to 6 months in depression. So you're not going to have enough episodes later for it to be counted as rapid cycling. They are associated with greater comorbidity and poor treatment resistance compared to non-rapid cycling bipolar disorders. Some people claim traditional teaching dictates that lithium is less effective in mixed affective states and rapid cycling, but the thinking is changing now. I'll come back to that. And there are new studies to show that's not necessarily true for rapid cycling in particular. So rapid cycling bipolar disorder, female preponderance, association with subclinical hypothyroidism, higher rates in bipolar 2, not 1, no genetic basis, not related to menstrual cycle, perhaps related to circadian rhythms. Rapid cycling and antidepressants. Rapid cycling is associated with prior exposure to antidepressants. We know that. Ralph Kupka study showed that all those years ago. Maybe it is because of association with more severe depressions. Maybe it is causative in acceleration because about 73% of the tricyclic antidepressant treated patients develop rapid cycling. This is a summary slide by Paul Keck in Comprehensive Psychiatry in 2003 to show you first-rank Schneiderian symptoms, paranoid hallucinatory states, delusions and hallucinations are common in bipolar illnesses, particularly bipolar 1 illness compared to bipolar 2 illness. Early onset for depression, onset is later, around 30. Here it is about 15 to 19. But the problem is correct diagnosis is not given for about 10 years, particularly for bipolar 2 patients. So the onset is later in many of our clinical practice because the diagnosis is missed. Early onset is not uncommon. It can happen in children. Early onset, there's more malignant cause and more suicides. This is a highly lethal illness, which we'll come back to. Early onset and more severe cause in substance abusers. And late onset in the elderly may occur as a result of other conditions. I've summarized the other conditions here. I'm not going to dwell on them. You're going to get the slides. Cerebral tumors, etc., need to be excluded. There are systemic conditions that need to be excluded that can mimic hypomania or mania picture. Drugs like levodopa, bromocriptins, steroids that are increasingly used in the post-COVID world. There's a possibility of patients switching into hypomania or mania. There are other organic causes, infectious causes, vitamin deficiencies. And there are other organic causes like including syphilis, general paresis of insane, MS, cryptococcal meningoencephalitis, which is not uncommon, Pick's disease with the frontal lobe dementia, etc. To address the concerns about potential overdiagnosis and overtreatment of bipolar disorder in children, particularly in the US, some of them are, of course, misdiagnosed ADHDs. A new diagnosis, disruptive mood dysregulation disorder, is included for children up to the age of 18 years who exhibit persistent irritability and frequent episodes of extreme behavioral discontrol. So this is a new category, disruptive mood dysregulation disorder. On average, how long does it take for the onset of major mood symptoms to diagnose? I've already answered that, 10 years. Here you have it. Bipolar 1, we don't do badly because a classic full-blown manic picture will give it away. So that's still bad at 5 years, but bipolar 1 is often delayed. Diagnosis with deleterious consequences. You treat patients with antidepressants without mood stabilizer cover. This is Felix Post's work all those years ago to show you the earlier the onset, the longer the delay. Less than 12 years of age, they're waiting 15 years. Adolescents, 10 to 12 years. 19 to 20, in his study, 4 to 6 years, etc. In general, bipolar disorder is, I can give you the answer, is more underdiagnosed than overdiagnosed, despite that not so methodologically sound paper by Zimmerman, published in British Medical Journal all those years ago, arguing overdiagnosis is the problem. That is not true. Subsequent analysis have clearly shown us. This is a paper by a friend of mine, Ali Hantouche, from Paris. All those years ago, he showed us under recognition is the problem. In the first visit, 72% of the patients in this decent sample of 537 patients were diagnosed as unipolar depression by French psychiatrists. When they used hypomania symptom checklist of Jules Sang's systematic evaluation, they found many of them converted to bipolar 2. You can see underdiagnosis is of the day, and this carries on to date. And then they carried the study again. Hantouche is from Algeria originally, so they included a sample from North Africa, Far East, and Europe. Large numbers of patients did the same thing and showed, after careful evaluation, significant percentage of patients who were diagnosed as unipolar converted to become bipolar 2 patients. And bipolar disorder, they showed, has very little cross-national variation. What is true in England, in Sri Lanka, and Far East is the same. So we have Afzal Javid with us as president of WPA, and WPA is taking an overarching view in educating clinicians across the world, particularly in low and middle income countries. Dr. Javid has kindly invited me to join a panel of psychiatrists to do this work, because education is so important. I'll come back to that. Is bipolar underdiagnosed or overdiagnosed? This is Fred Goodwin's summary, the great man, the living legend. There are 5 well-designed major studies of bipolar 1 patients, indicating that for each one properly diagnosed, there's one improperly diagnosed, primarily as unipolar depression, i.e. 50% underdiagnosis. This is not to say, my friends, that some overdiagnosis is not going on, but underdiagnosis is clearly the predominant problem. Problem of self-diagnosis for secondary gain, to get out of debt, trouble with law, looking for a psychiatric report, or simply socially acceptable, or even fashionable in Bollywood rave parties is an issue. So Stephen Fry thinks he has bipolar disorder. Some people claim he's got a narcissistic personality disorder. Anyway, Jules Sangs said this in an editorial in British Journal of Psychiatry. We can safely assume that the prevalence of bipolar disorders is seriously underreported, and the burden of bipolar disorder, estimated by World Health Organization to be much lower than that of depression, will as a consequence have to be reassessed. So to summarize this part of the talk, many patients with apparently unipolar depression may suffer from a clinically relevant bipolar spectrum disorder. This has important implications for mood disorders research and, more importantly, your clinical practice world over. Future classifications of mood disorder should include dimensional assessment of symptoms and affective temperament. So major depressive disorder with cognitive dysfunction, with hyperthymic temperament, things like that. So which phase of the bipolar disorder contributes most to disability? Certainly depression. These are famous researchers: Louis Judd, Felix Post, Russell Joffe, the Canadian psychiatrist now in US, Ross Baldassarre, the Italian psychiatrist now in US, clearly showing depressive morbidity, plus what's not on the slide, mixed states, which includes mixed depressive states, are the worst things to treat. The Stanley Foundation Bipolar Treatment Network is a huge network, has huge database. It's across US, Holland, Netherlands, and 2 centers, Freiburg and one other in Germany. Here they show the first symptom of bipolar disorder in approximately 50% of the patients is depression. When patients present to the general practitioners in Europe, UK, and to psychiatrists to some extent straight in Sri Lanka, 50% of them, the first episode of depression. Unless you have good vigilance, looking for some of the indices of bipolarity, it is very hard to pick up who might convert into bipolar disorder. The first diagnosis is always depression. These are some of the barriers to correct diagnosis. Patient may not seek help due to lack of understanding, recognition of illness, embarrassment, stigma, and denial of illness is a problem. I have a friend whom I have reconnected, a physician in US. He is classic persistent hypomania, but denial of illness is the problem. It is clearly impacting on his work and other relationships, but getting them to accept is a huge problem. Diagnosis can be difficult, variation in symptoms, multiple phases of illness, a spectrum of patient types, overlap with psychotic features and other affective illnesses. Often, bipolar 1 patients with psychotic symptoms are misdiagnosed as schizophrenia. I have made that mistake. I'll openly admit, when I was a registrar in Coventry and Warwickshire, the consultant will come and tell me, no, this is a bipolar illness. She's manic with psychotic symptoms, not schizophrenia. Lawrence Macy used to tell me that. I learned from him. Comorbidity with other psychiatric illnesses, symptoms due to other causes, like we discussed extensively, you can go through at leisure, and diagnostic criteria have limited limitations. ICD never recognized bipolar 2 as a syndrome. They included hypomania as a illness only very late. Barriers to diagnosis, current diagnostic classification failings, failure of clinicians to recognize hypomanic symptoms, failure of patients to report hypomanic symptoms. There's state-dependent memory distortion. So if you admit a patient with depression, they're clearly depressed, they're not going to be able to tell you they had hypomanic episode in the past, right? They will not be able to tell you, so you need to speak to significant others. Collateral history becomes very important. Early accurate diagnosis world over clearly impacts clinical outcomes. Misdiagnosis can lead to inappropriate treatment, aggravated course, cycle acceleration, and a future treatment resistance. Delaying correct diagnosis is associated with increased risk of suicide attempts and completed suicides. Inappropriate antidepressant use in bipolar disorder can induce hypomania, mania, or rapid cycling. So accurate history taking, looking for family history in those with 15 to 20%, collateral history, and longitudinal follow-up, use of mood diaries can help. Some of our patients are educated patients who can keep detailed diaries of their mood symptoms. Educational of physicians, such as today, is important. Education of physicians recognizing bipolar 2 is important. Increasing patient awareness of symptoms of bipolar disorder, particularly reporting mild mood elevations, is important. So there's a public health campaign here. So hope WPA will do some of this work in member countries. Evaluate, I'd like to put it to you, try and evaluate all major depressive disorder patients for manic or hypomanic and subthreshold symptoms. Improving detection rates, I've listed mood disorder questionnaire here, easy to use 5 to 10 minute questionnaire, self-rated 13-item questionnaire, simple yes/no answers regarding hypomanic and manic symptoms. Nasagami has his own, and Yul Sangs, as I mentioned to you, had hypomania symptom checklist. So in terms of switches, this is all Malcolm Pete's work in British Journal of Psychiatry to show patients treated with only antidepressants, tricyclic antidepressants, switched more than patients treated with SSRIs. Patients treated with SSRIs, see, there was no differences between SSRIs and bipolar depression in his study. So what are the individual susceptibility factors for treatment emergent affective switches? And roughening of the illness, acceleration. Female gender. Females are more likely to cycle because there's female preponderance in rapid cyclers. Bipolar 1 patients are more likely to cycle. Personal or family history of antidepressant-induced mania or family history of bipolar disorder, substance misuse, comorbidity, and early onset patients are more likely to switch than the others. You can switch it the other way around. Say what patients are less likely to cycle. Adult patients, bipolar 2 patients, no personal or family history of antidepressant-induced mania or bipolar disorders, no substance misuse comorbidity, later onset. Okay, so it's not rocket science. So this is Ross Baldassar and his work to show you 50% of the patients with bipolar disorder are still receiving antidepressant monotherapy. They are not receiving the valproate, carbamazepine group, lithium, or atypical antipsychotics, which are the first-line treatments these days in most major guidelines world over, right? And this is a problem. Most antidepressants we know, they don't control manic episodes, and they may actually induce mania in bipolar 1 patients for sure, and particularly in long-term treatment as opposed to short-term treatment. Guy Goodwin asked the question, along with Ross Jamieson, what is the difference between their monograph, Manic Depressive Insanity in 1990, and when it was published again in 2007, 17 years later? In 2 decades, what has changed? And these are the observations: more cycling, mixed states, and lithium resistance. Young age of onset, 10-year-olds, 12-year-olds, 9-year-olds, prepubertal mania, and increased prevalence amongst young. what is the role of antidepressants? And they offer the explanation. There's a tenfold increase in antidepressant scripts since the second generation antidepressants came into being. When Dr. Javed and I and Dr. Kure were junior doctors all those years ago, 85% of the scripts were by psychiatrists, versus 86% of second generation antidepressant scripts are now given by non-psychiatrists who are less able to pick up hypomania or bipolar illness. There's a huge education that needs to happen amongst general practitioners, at least in the Western world, and to some extent, general practice is developing in Sri Lanka too. Most adult bipolar patients have already been on antidepressants by the time they see a psychiatrist. And this is the problem. This is what contributes to cycling and roughening of the illness. Treatment emergent affective switches, TRs, is a better terminology than antidepressant-induced mania or haloperidol-induced dysphoria, because it avoids these kind of terminologies. It's prone to error, as causality cannot be proven beyond doubt. Some doubt this and argue that switches are a natural part of the illness, regardless of what you may do. It is nature that is doing this. Then they say pre-treatment switch rates, pre-antidepressants, pre-lithium switch rates are no different to present day switch rates. They quote antidepressant withdrawal mania. You're withdrawing antidepressant, patient is becoming manic. So it's a natural part of the illness. So why is antidepressant withdrawal causing mania? They say switches, if at all, attributed to SSRIs are much lower than tricyclic antidepressants. I've already showed you the old studies by Malcolm Peet in Sheffield, at that time in Sheffield. A more recent study, STEP-BD, the largest effectiveness study ever conducted in the field of bipolar disorder, like KT and STAR-D, in fields of schizophrenia and depression. Yeah. And Geddes' meta-analysis in British Medical Journal have shown such high rates into mania and cycle acceleration is not true, right? I'll show you some of these studies and studies here. STEP-BD study, Gary Sachs was the principal author. Here they are treating patients with mood stabilizers of various kinds, antipsychotics. They add paroxetine or bupropion as a NDRI, 16-week study. If you look at the switch rates, there are no differences in switch rates in those who received antidepressants versus those received placebo, right? But of course, these patients had mood stabilizer cover. They're not giving these antidepressants unopposed. So in terms of predominant mood disturbance in bipolar disorder, at the end of the day, is depression. And this is an interesting study by Louis Judd in National Institute of Mental Health Collaborative Depression Study in 2001. They followed up 35 patients with bipolar 1 disorder and 71 patients with bipolar 2 disorder on a weekly basis, doing symptom checklist over a 15-year period. It's a painstaking study to measure symptom status on a weekly basis for 15 years. What did they learn? What did we learn out of this study? Here they're showing you 31% of the time bipolar 1 patients are ill, they're actually depressed. So depression is the bulk of the problem in bipolar 1, I've already told you. 52% of the time patients are ill, patients are depressed in bipolar 2 disorder. If you compare that with manic, only 10% of the time bipolar 1 patients are ill, they're manic, and bipolar 2 patients by definition don't have manic episodes, have only hypomanic episodes. If you look at the ratio of being depressed versus manic, for bipolar 1 disorder, it is 3:1. And for bipolar 2 disorder, it's almost 40:1. So the predominant problem in bipolar disorder is depression, not mania. But of course, these are not all syndromal depression. Some of them are some subsyndromal depression, nevertheless, dysfunctional depression. So significance of subsyndromal symptoms, they contribute to earlier relapse. That's been shown by various others. The guy from Cambridge and Louis Judd more recently. Psychosocial and they add to psychosocial and cognitive impairment. They impair people's work relationships, personal relationships. And this is Kreplin's Manic Depressive Insanity and Paranoia monograph. You can see depression, the blue is the problem. Involutional melancholia, as he called it, is the problem across all age groups, starting from 15 to 65 here. So threats of suicide, bipolar depression is the most lethal psychiatric illness known to mankind, with almost 20% suicide rates. Only 5% of the patients with schizophrenia kill themselves, 5% in major depressive disorder. In here, it is almost 20% in bad centers. There's only one illness that comes close to such high suicide rates, that is untreated eating disorders, anorexia nervosa, right? In more recent data is more encouraging, 8 to 10%. That is reflecting better diagnosis and better treatment of bipolar disorders. Suicide attempts can range from 20 to 50%. So this is a problem. And this is standardized mortality rates in Yule's Angst study in the Zurich cohort, showing you very high suicide rates here, SMRs. And you can see the treatment effect, how significant the treatment is. By treating patients effectively, you can prevent a malignant course. Compare the SMR for suicide with cardiovascular problems and cerebrovascular problems, 2.2 and 1.6% versus 29.2%. It is estimated that there's a low ratio of attempted suicides to completed suicides in bipolar disorder as compared to the general population. This suggests that suicidal behavior in bipolar disorder is highly lethal. Now, if you look at the general population, if 26 people attempted suicides, 1 is likely to kill themselves. That's the statistic. And if you take major depressive disorder, that's about 10:1 here. And in bipolar 1 depression, it's 10:1. So attempt versus suicide ratio as a measure of lethality for bipolar disorder is 5:1. So this is the most lethal disorder known to mankind, hence the importance of making a good diagnosis and treating them effectively. Suicidal acts, I plotted the course here. It never goes away, but earlier years are more lethal than later years. So what are the risk factors, you might ask? There's only one study by Ross Baldessarni all those years ago. I'll come back to that. Now, most occur, these suicides, during depressive phase or mixed affective states. Mixed affective states is a risk factor. So avoid antidepressants like plague in mixed affective states and try to treat mixed affective states effectively. There's only one prospective data of 1,000 bipolar patients followed over a decade, estimating risk factors at 1 year for suicide. I've summarized it for you here today. These are risk factors in the current episode: severe depression with anxiety, agitation, and global insomnia, mixed dysphoric mania, mood cycling in episodes, substance misuse, transitional periods, impulsive and violent behavior. And these are from the history, and you can go through at leisure in time to come. Now, uncovering bipolar disorder versus unipolar depression, symptom profile studies, what have they taught us? Think bipolar, if it is early onset, psychotic symptoms, postpartum onset, treatment-resistant unipolar depression, antidepressant-induced hypomania or mania, cycle induction at the start or stopping treatment. Changing the type of depressive symptoms over time. Your patient is becoming agitated, activated, maybe a sign of hypomania, reinforcing what I've already told you. So differences in symptom profile alone, these are suggestive, but none are shown to be pathognomonic or sufficiently characteristic. On a probabilistic basis, phenomenology is only subtly divergent between major depressive disorders and bipolar disorders. To this end, current research is focused on identifying early clinical biological markers. To date, we don't have any. Clinical diagnosis remains contingent upon history of mania or hypomania. This has been a source of much debate, as clinically mania and hypomania do not constitute the predominant mood state, and hypomania is detected often retrospectively. Often patients don't remember or report it. And this is seen as an undue bias towards one aspect of the illness. Research domain criteria is searching hard, looking for biomarkers across similar disorders: schizophrenia, schizoaffective disorders, bipolar disorders, ADHD, autism, etc. In other words, a taxonomy based on empirical multi-domain data, but to date, we don't have any significant biomarkers to make a diagnosis or to measure severity of bipolar illnesses. Compared to bipolar 2, bipolar 1 depressive patients have what? More psychotic features, more hospitalizations, more agitation and irritability, more severe depressive episodes. Hence, they are less likely to meet the criteria for rapid cycling, longer major depressive episodes. If you tip it the other way around, compared to bipolar 1, bipolar 2 patients have more of all of these things: anxiety symptoms, rapid cycling, episodes and shorter intervals, more episodes and shorter intervals, more premenstrual dysphoria, etc. At the end of the day, cognitive difficulties is a core feature of bipolar disorder, occurs during prodromal phase, like in schizophrenia, more severe during illness phase, may persist during remission, but the cognitive dysfunction is more in schizophrenia and less in major depressive disorders. And this slide summarizes what I've already told you about the 3 disorders here. So in terms of effect of medication, these are medications that can help, but none are used in prime time. I've just listed for sake of completeness. Valproate we now know is neurotoxic and can dampen cognitions. If somebody takes more than 2 grams of valproate for more than 5 years, particularly if they're older patients, cognitive dysfunction might become a problem. Anticholinergics, just one drug alone, cholinergic burden. Somebody taking a detrusor instability, anti-detrusor instability drug, an antidepressant with strong anticholinergic properties, quetiapine with anticholinergic properties. If you combine an antihistamine, if you combine what they call as anticholinergic load, can affect cognitions. Jury is out about benzodiazepines and their effect on cognitions, but high doses sometimes are come across in nursing homes. Patients on 5 milligrams 3 times a day of diazepam, for what, God only knows, can dampen cognitions. Topiramate can dampen cognitions, and no guidelines worth their salt recommend topiramate first or second line in the treatment of bipolar disorders. It might help with weight loss, but there are other ways of inducing weight loss, like GLP-1 agonists, which I'll come back to if I have time, or SGLT2 inhibitors that may help in preventing bipolar disorder, some people believe. Lithium is a controversy. We all have seen patients, lithium can affect people's thinking, etc. But now new research show lithium can actually increase gray matter volumes, right? So in theory, lithium can prevent dementia, is what the new research is showing. And you don't need high levels of lithium to have this particular effect. Even lower levels can be effective, but lower levels, of course, will not prevent manic episodes. To prevent manic episodes, you got to keep your levels at about 0.8 or more. Charlie Nemiroff's work has shown even in depression, you might need levels of 0.8 or more. One of the reasons lithium was considered ineffective in rapid cycling and ineffective in mixed affective states because of low lithium levels is what new research by Charlie Nemiroff and others are showing. Ventricular volumes, there are differences, as you can see, in multi-episode bipolar patients. There's frontolimbic disconnection we know in bipolar disorders, and these are some of the findings. It's still 7th leading cause of disability worldwide, not as big as unipolar depression, but still it's ahead of COPD and asthma. Considerable personal burden. An individual with onset of bipolar disorder in the mid to late 20s effectively loses 9 years of life, 12 years of normal health, 14 years of work relativity. Then there's other disasters like divorce, problems, etc. This is a complex and a pleomorphic illness. There's axis 1 comorbidities, substance misuse, anxiety disorders, axis 2 comorbidities. Then, of course, there's medical comorbidities with this particular illness. So there's a lot of research, which I don't have time to cover here today, in managing the medical comorbidities and preventing bipolar disorders. Even in non-diabetic patients, anti-diabetic drugs may seem to have a preventative role in some of the bipolar disorder patients because they can reduce inflammation, they can reduce anhedonia, etc. And this research is raging right now. Comorbidities of the day at the end of the day, 65% comorbidity. About quarter of the patient had one axis 1 comorbidity, 20% had 2 additional diagnoses, another quarter had 3 more additional diagnoses. Substance misuse comorbidity and anxiety comorbidity is a problem. Effect of substance abuse on course of bipolar disorder is basically bad news. Early onset, more frequent episodes, mixed episodes and rapid cycling, more suicidal behaviors, slow symptom remission, poor adherence to treatment regimens, and more likely to be lithium refractory. Personality disorders are very common, not just borderline personality disorders. All other axis 2 disorders are common. And this is one way of differentiating between a clinical conundrum between bipolar disorder and borderline personality disorder. Bipolar disorder, onset in teens and early 20s. Borderline personality disorder, there's no defined onset. Bipolar, no spontaneous mood changes. Mood changes in borderline is precipitated by internal and external events. Euthymic, dysphoric, anxious, and elated mood shifts are common in bipolar. Euthymic, dysphoric, anxious, and angry mood shifts, but elated mood per se is rare in borderline personality disorder. There's episodic impulsivity and risk-taking related to the mood episode. There's chronic impulsivity and risk-taking in borderline. Episodic suicide attempts related to depressive episodes and mixed episodes. Recurrent suicidal gestures associated with both depression and internal and external precipitants. Self-mutilation is rare in bipolar disorder, very common in borderline. If you ask the bipolar patient, they will endorse depressed mood as a descriptor, whereas borderline patients endorse emptiness as a descriptor. Family history is negative for bipolar 1, 2, and recurrent depression in borderline personality disorders. That's one way of differentiating. And in real life, these are complex presentations. Misdiagnosis is common. That's why a second opinion might be necessary in some of your patients. And of course, some patients have comorbid borderline personality disorders. Obesity is very common, some related to pharmacological treatments like olanzapine, quetiapine, etc. Affects brain connectivity. Obesity clearly affects brain connectivity. Roger McIntyre's work shows that there's more anhedonia and more cognitive dysfunction in obese bipolar patients. So there's a preventative role there. Diabetic prevalence is common. Tight control can prevent bipolar disorder because it cuts both ways. Diabetes can induce bipolar disorder and depression. As obesity and diabetes are brain hazards, it's important to prevent these things. We'll come back to that. Relative cardiovascular mortality is increased, not as bad as schizophrenia, but bad enough. Migraine prevalence is high, twice the general healthcare cost. Most of the comorbidities are associated with depression. Most of the medical comorbidities are associated with depression. And this is again a slide showing you very similar to schizophrenia. All of these, obesity, smoking, diabetes, hypertension, etc., are higher in bipolar disorders, not as high as in schizophrenia. The need for improvement in treatment options are very clear because recurrence is a major problem, and psychosocial and vocational impairment is a major problem in patients with bipolar disorders. Over 1 year period, functional recovery occurred only in 24% of the patients. In this famous study by Maurizio Tohan, he followed up bipolar 1 patients, 166 patients with first episode over a 2 to 4 year period. Here he is showing you the so-called subsyndromal recovery using DSM criteria happens in 98% of the patients. But symptomatic recovery using YMRS less than 5 or HAM-D less than 8 is happening only in 72% of the patients. But if you use occupational and residential status criteria and functional recovery, only 43% of the patients at the end of 2 years after index episode is having full functional recovery. These are some of the explanations for why patients have residual symptoms. I suggest that you go through at leisure in the interest of time. So to summarize this part of the talk before I look at treatment issues, bipolar disorders are seriously under-recognized, primarily because clinicians fail to include family members and significant others in the evaluation of patients with depression. The under-recognition of bipolar disorder and inadequate treatment of its depressive phase convey substantial cost to the society in Sri Lanka and world over, primarily through loss of productivity and a doubling of general healthcare cost. Psychiatric and medical comorbidities largely associated with bipolar depression contribute substantially to disease burden. Unite survey by Roger McIntyre asked the patient the needs of patients with bipolar disorder, aspects of care the patients would like to see improved. The top of the pops is better treatment of depression, less risk of weight gain with all these olanzapine-like. Olanzapine is now second or third line in most major guidelines because of metabolic side effects. There are much better medications, prevention of relapse in depression, improved functionality, less risk of sleeping difficulties, etc. So that brings me to the importance of evidence-based treatment of this burdensome illness with high comorbidity and suicides, high suicide rates amongst all Axis 1 psychiatric disorders. These are some of the treatment challenges. Bipolar disorder is often under-recognized and undiagnosed. Comorbidities is common and can hinder diagnosis. Depression is the predominant symptomatic phase, can lead to misdiagnosis. It's a chronic disorder in many, need for long-term symptom stability across poles. And the phenotypes, there are many phenotypes, bipolar 1, bipolar 2, rapid cycling, and mixed affective states. And bipolar 1 itself can have many genotypes. Only time will tell. In terms of acute treatment, we all know all of the antipsychotics, except olanzapine is not first line, can have quite a good effect in acute mania. So can lithium and valproate. Olanzapine is downgraded. Adjunctive benzodiazepines is fine. If you like olanzapine because it's sedative, if you are using aripiprazole, use benzodiazepine for a defined period of time and then withdraw the benzodiazepine. That way, the control is in your hand. You're taking the drug off. Remember to take the drug off. Have the scientific rigor to take the drug off. Whereas if you use drugs like olanzapine with antimuscarinic effects, antiadrenergic effects, and other side effects, it's hard to stop the drug. You can't suddenly make olanzapine aripiprazole-like or lurasidone-like. Depression, the top drugs are quetiapine in acute treatment, lurasidone, cariprazine. Lurasidone has good data. Cariprazine has good data. Lamotrigine, is it effective in acute depression? Many feel it is not because up titration takes time, but there's one study showing some efficacy. Lithium, there are new studies showing efficacy, even though there are at least 4 or 5 studies in the meta-analysis showing lithium is not very effective as an acute antidepressant. Avoid antidepressants as possible. Less of a chance of switch if it is an acute treatment. Combinations of antipsychotics and mood stabilizers, cotabine, lamotrigine, lurasidone, lamotrigine, cariprazine, lamotrigine, aripiprazole is effective. Aripiprazole is not effective in acute treatment or in maintenance treatment in bipolar disorder. Acute treatment it might be, but not in the maintenance treatment. Mixed states, avoid antidepressants like plague, no question about it. Valproate and antipsychotics are better. Lurasidone, cariprazine may be the way to go. And lithium, some reanalysis showing lithium may well be effective in acute mixed states too, but the traditional teaching is that lithium is not very effective in mixed states. Adjunctive combination studies is the norm. All of the antipsychotics have combination studies with lithium and mood stabilizer. Key questions in maintenance treatment are these: for whom, when, for how long, and with what. For whom, because of the high recurrence rate, most people should get it. And the NICE guidance talking about consider long-term treatment. One severe episode of mania with functional impairment, with risk and adverse consequences. You can't afford to have another one. 2 less severe episodes of illness is what they say. Yul Sang's long-term work shows that no period during the 40-year follow-up is risk-free. So long-term treatment is often needed in many patients, and these are the exceptions. Someone with severe psychosocial stressors who is now retired. Someone with chaotic lives who is now more settled. Someone with substance misuse who is now stable. These are special situations. With what? There are at least 5 drugs that are effective in monotherapy in placebo-controlled studies lasting 1 year. Keywords are monotherapy, placebo-controlled for 1 year. They are listed here. 1 year data for valproate semisodium in monotherapy, but it's not placebo-controlled. Few small control studies for carbamazepine versus lithium, but not well-designed double-blind placebo-controlled studies with its not sufficient samples. All studies assessed here are enriched designs. So they treat the patient with the drug, get the patient better. Only the responders are then randomized to the drug itself or placebo. And this is known as enriched design, which has its own problem. It's a design that is hardly ever to fail. So we'll come back to enriched design if you have time. So lithium efficacy is clearly established in acute mania, in long-term prevention of manic relapses. It is clearly anti-suicidal, more so than clozapine in schizophrenia. That Cipriani's meta-analysis clearly showed it is anti-suicidal. In this highly lethal illness, that may be significant. It prevents dementia. Epidemiological data from ANGS shows that even at lower levels. But be aware, you need about 0.8 to prevent most episodes. So lower levels are little meaningless here. It increases gray matter volume. We have spoken about side effects, acute, long-term can be problematic. They are familiar to you. 2 of the major Achilles heels of lithium are compliance. Patients don't take it. If they stop the medication suddenly, there's rebound. That's likely to switch into the opposite pole within 3 months. And these are the biggest issues, and it's not available in an injectable form. Side effects of lithium are familiar to you, so I'm not going to go through it. There is some new evidence to show that lithium can work. I've spoken about Charlie Nemirov's work and the levels, and STEP BD showing lithium was as effective as lithium plus antidepressants. Toxicity is very familiar to you. As psychiatrists, I don't need to tell you, but the therapeutic range is important. Teratogenicity, avoid in first trimester for sure, but Epstein's anomaly is overstated. It's 1 in 2,000, not even 1%. Effects of rapid discontinuation. I've already spoken about discontinuation mania. It clearly prevents manic episodes. It prevents any mood episode. It's not so impressive in this particular analysis in preventing depressive episodes, but more recent analysis is showing it is. In this particular John Geddes meta-analysis, it didn't do very well in preventing acute depression, but long-term certainly it prevents. This is the famous Charlie Borden study with valproate semisodium to show it works just as well as lithium. This is a study claiming olanzapine is slightly better than divalproex, but they both work okay. These are some of the divalproex side effects. There is this syndrome, I won't dwell on it, called syndrome of irreversible lithium effectuated neurotoxicity. It's a cerebellar syndrome. Patients might need hemodialysis. So any patient with the encephalopathy type of picture, lithium could be the issue, and those patients might need hemodialysis, and this can happen at normal levels. What we are trying to do is to measure lithium's extracellular levels in our clinics. But this is the intracellular levels in the brain that are not really a proxy for extracellular levels that are measured in serum. So be aware of that. Carbamazepine, which is hardly used because of its interactions, pharmacokinetic interactions, and because of its toxic side effects. It's a third-line drug. Lamotrigine has the opposite profile of lithium. In terms of preventing depression, it does beautifully well in 18-month study by Guy Goodwin and others, whereas its anti-manic efficacy is not as efficient as lithium or valproates. It's a better antidepressant mood stabilizer. In terms of in rapid cycling, there are 2 negative studies with lamotrigine in bipolar 1 rapid cyclers, but it is the drug of choice for bipolar 2 rapid cyclers, for sure, lamotrigine. Lamotrigine, again, in acute depression, it's hard drug to use because you got to titrate it very slowly. It takes 4 to 6 weeks, so it might not be that useful in acute depression. But if you combine it with quetiapine, that can work fast, with lurasidone, cariprazine, that are better in terms of side effect profile than quetiapine, particularly lurasidone and cariprazine, they act fast. So you can combine these drugs with lamotrigine to get good effect over a period of time. This is a combination study known as the Lamlate study by Vanderloos et al. In this study, they combined lamotrigine and lithium from the word go, and they showed good effect at 8 weeks, and more importantly at 68 weeks. So that Lamlate combination is another combination that can work instead of using quetiapine. Sequel study by John Geddes, published in December 2015. They showed combination of quetiapine and lamotrigine is better than quetiapine monotherapy. They had folic acid as an option as well. Here you are using 2 different drugs. Quetiapine works through norquetiapine, which is the active metabolite that increases noradrenaline and dopamine, whereas lamotrigine is an inhibitor of voltage-gated sodium channels, and it is thought to work by reducing presynaptic release of glutamate as an excitatory neurotransmitter. Here there are 2 synergistic actions. Conventional antipsychotics are widely used. I'm not going to spend too much time on it, except to make the point they are clearly antimanic. So are the second generation drugs. They're not simply sedative. And efficacy of second generation antipsychotics and first generation antipsychotics is independent of their antipsychotic effect. Their mood stable, they can control the mood. Olanzapine's picture is very similar in terms of prevention of episodes like lithium. Olanzapine fluoxetine combination is available in the States and licensed for treatment-resistant depression and for bipolar depression. But I would not recommend to you, if olanzapine is relegated to second-line use, why would you want to use olanzapine and fluoxetine? Why would you want to combine fluoxetine with an active metabolite, norfluoxetine, with some half-life of 7 to 9 days? I'd rather combine other combinations like lurasidone, not even quetiapine, lurasidone and sertraline or citalopram, or cariprazine with sertraline or citalopram. Avoid fluoxetine in these patients. Avoid high doses of venlafaxine, which is very powerful, or high doses of escitalopram with dose-dependent side effects. So aripiprazole, I've already told you, is not good in preventing depressive relapses, but it does have data in preventing manic relapses. There are with quetiapine, there are Embolden 1 and Embolden 2 are studies that show quetiapine is effective in depression. Now we have data from lurasidone and cariprazine too. But they were all enriched designs, and that's the problem. Say, for example, RCTs have proven quetiapine at both doses are effective with depression. RCTs have proven it's effective as monotherapy and combination therapy. It's also effective in unipolar depression. But the dropout rates with quetiapine is high because of side effects, postural hypotension, anticholinergic side effects, sedation, etc. 1/3 of the patients with even lower dose dropped out, 41% with 300 milligrams in Michael Thesa's study. Most dropouts were due to adverse events or withdrawal of consent. Use of enriched design can be problematic. It overinflates the patient's ability to, the drug's ability. Drug's effect sizes are overinflated. So how does enrichment cheat? An example, quetiapine versus placebo augmentation of lithium or divalproex in bipolar 1 disorder, enrolled almost 2,000 patients. Dropout during enrichment phase, 68% of the patients dropped out. Randomized to treatment, only 628, 32%. A further 44% dropped during 2 years of follow-up. Only 27% with placebo. It can inflate the effect sizes. So in enriched design, the effect size of lithium in preventing manic episodes is 22. In a non-enriched design, effect size is odds ratio of 2. So an enriched design inflates the effectiveness of lithium by 10-fold. What happens if you have a drug that does not work? And in an enriched design, its effectiveness could be inflated. So if you take inverse, that is what I showed you here is known as the randomized discontinuation design. Here, I'm talking about inverse randomized discontinuation designs for major depressive disorder here. Placebo responders who responded to major depressive disorder, which could be up to 40 to 60%, were continued on placebo or then switched to an antidepressant, real active drug. Those on antidepressants had twice the relapse compared to placebo. So the study researchers claimed that the antidepressant make patients worse, which is not true. It is just that this design never fails. The falsifiability of a drug efficacy is reduced. So just be aware of these designs. Of course, quetiapine monotherapy, what's the bottom line? It has the best chance of working only in those in whom it worked to begin with, in whom it was tolerated to begin with. And even then, there are problems with efficacy and tolerability in the long run. There are better medications than quetiapine now, lurasidone and cariprazine. So I certainly wouldn't bother with quetiapine anymore personally. What do you do if your patients will not take the medications? Bipolar 1 patients with psychotic symptoms. Compliance is a problem. Lithium is not available in an injectable form. Divalproex is not available in an injectable form. So you got to use. This is risperidone long-acting injection showing efficacy in bipolar 1 patients. There's some data for aripiprazole maintenance. Paliperidone, there's some data, but we have not seen any convincing data. I have no reason to suspect in clinical practice it cannot work. They can all work in preventing psychotic symptoms and preventing manic episodes for sure in those bipolar 1 patients in particular. Maintenance studies, if one starts with mania, their relapse in 6 months, over 6 months after they have got better, is usually the opposite pole, and vice versa. If you treat the depression, the relapse is usually mania. In the short term, in less than 6 months, the relapse is always the same pole. What does that tell you? What does that tell us is that in the short term, if someone relapses, it is still the same episode you're treating. To show effectiveness, the index drug, the drug in question, must prevent the opposite pole. Combinations is the order of the day these days. Idea is to use synergistic treatments that work in different pathways. Avoid irrational combinations like treating with 2 antipsychotics like quetiapine and lurasidone. Balance study was an interesting study done in Oxford. It used a non-enriched design. They treated patients with lithium and valproate over a period of time. Those who were responders were then randomized to continue on the combination or switch to lithium or valproate. What did they find? This is in this landmark study. Lithium monotherapy was superior to valproate regardless of baseline illness severity or index episode. Most apparent for prevention of depressive episode, goes against some literature. Combination of lithium and valproate did better than valproate alone. Most apparent for prevention of manic relapses. There was no significant differences between lithium and combination therapy. That's pretty good for lithium. In patients not responsive or partially responsive to lithium, it is better to add the valproate than switch to valproate. So these are important clinical practice guidelines. Go through at leisure, right? And long-term antidepressants, the most controversial area. A subgroup of patients will need it with quetiapine. I would say lurasidone, cariprazine instead of quetiapine, or lamotrigine, or lithium, or valproate, or carbamazepine. I'll avoid carbamazepine. Avoid in mixed states and rapid cyclists. In bipolar 2 patients, can you get away with it? There are some studies to show the magnitude of effect of antidepressants in any bipolar patient is very low. This is a very low effect size, 0.16. So less chance of switching in bipolar 2. You could also interpret it by saying antidepressants don't work just as well in bipolar depressions. It'll be okay for short term, 6 to 12 weeks. Higher switch rates in the long term. Avoid long courses for more than 3 months. That's what most guidelines say. Avoid certain drugs I've already spoken about. Tricyclics are hardly used. Long-term monotherapy is not recommended in any major guidelines. Rational combination therapies with first-line options are often necessary in many patients. These include lithium valproate atypical antipsychotics, particularly lurasidone and cariprazine and lamotrigine. There are anti-manic mood stabilizers, valproate, lithium, carbamazepine with its shortfalls, and all antipsychotics. Lamotrigine is a weak anti-manic agent. Antidepressant mood stabilizers, they are stabilizing the illness from below baseline. Lamotrigine, quetiapine, lurasidone, cariprazine, olanzapine, fluoxetine combination with the high caveats, lithium, valproate, and carbamazepine. Bimodal, true bimodal stabilizers are quetiapine, lurasidone, lithium, and then others with weaker propensity. Proposed alternative terminology, instead of calling them antidepressants in bipolar disorder, call them monoamine agonists. Because there are significant connotations. What antipsychotic? What do I want antipsychotic for when I have a bipolar illness? Call them dopamine blockers or dopamine modulators. Lithium and valproate with connotations, call them second messenger modifiers. Benzodiazepines, tell your patients they are GABAergic agonists. Sounds better? They might increase compliance. ECT is very much second or third line unless there are significant psychotic symptoms, not eating and drinking, and catatonic symptoms. Depending on patient acceptance, concerns about cognitive side effects. Of course, you have to use ECT very carefully in bipolar 1 patients. You can switch the patients into mania. But of course, ECT can be a treatment for mania too, to abort an acute attack. Last resort remedies, that's a D2, D3 neurotrophic agonist mentioned here. Modafinil is used sometimes. 3 drug combinations are sometimes necessary. Lithium valproate and lamotrigine. Lithium valproate and lurasidone, cariprazine. RTMS, there's some data on bipolar depression. There are some repurposing opportunities, reducing inflammation and obesity. Certain DPP-4 inhibitors, GLP-1 agonists. There are changes in the glutamate and GLP-1 agonist recalibrates the brain circuits and improves cognitions and anhedonia and induces weight loss. And there are some studies to show GLP-1 agonists like Victoza can prevent bipolar disorders. Insulin, anti-inflammatory drugs, minocycline is a glutamatergic agent and an antioxidant and an anti-inflammatory drug. There's a lot of research going on in this particular area. These are not recommended. In terms of mechanisms, remember bipolar disorder, even bipolar 1 is probably a phenotype representing a heterogeneous group of genotypes. The point I made already. 2 drugs may work additively or synergistically on the same pathophysiology, or they may address different pathophysiologies, bringing a wider range of patients under the compass of response. In terms of combinations, polypharmacy is generally frowned upon, but it is often necessary in disorders like diabetes, hypertension. See it as a evidence-based combination treatments than polypharmacy. In smoking, we use NRT drugs and Champix. Alcoholics have multiple medications sometimes, nalmefene plus acamprosate. Post-ECT maintenance, often patients have an antidepressant plus lithium. Schizophrenia, the direction of travel is all about treating different symptom domains. An antipsychotic to control the positive symptoms, something else to improve negative symptoms and cognitions in time to come. Clozapine, there's not a single randomized controlled study in acute treatment or maintenance treatment. And psychosocial interventions, they're good. They should be used as per the NICE guidance. There are various kinds: family therapy, interpersonal therapy combined with social rhythms therapy, popularized by Ellen Frank, wife of David Kopfer from Pittsburgh. A recent Canadian study found no difference between CBT and psychoeducation. One point to make before I open it up: balanced study people carried on with another study called sequel study. Sequel study was a combination of quetiapine and lamotrigine versus quetiapine monotherapy versus folic acid monotherapy. In this, they showed at 12 weeks and 52 weeks, combination of quetiapine and lamotrigine is very useful in preventing bipolar depressions. Quetiapine acts fast, lamotrigine takes time because of the titration to avoid serious vascular rashes. So the combination makes pharmacological sense, and they recommend using this combination, and lamotrigine is well tolerated. Serious vascular rashes are less than 1%. And they say the combination works fast. And as I told you, even though the study used quetiapine, I will use now lurasidone or cariprazine because it's a much better tolerated drug than quetiapine. Quetiapine to me, even at 300 milligrams, the older psychiatrist like Antran Garagasabe, Neil Tamimuthu, and Professor Kure and others, Dr. Javid and others will remember, it's like Malaril. It's a better Malaril, like postural hypotension. Remember the side effects: sedation, anticholinergic side effects. And now there's an additional problem, which is even worse than Malaril, which is the metabolic side effects. And the anticholinergic side effects in the older patients, strong anticholinergic side effects can worsen their cognitions along with other anticholinergic drugs they may be on. Many of them are on these medications. So I've tried to cover as much as I can in the little time that we have had. I'll open it up now for questions. Please identify yourselves and ask me anything you'd like. Let's start with the Sri Lankans.
You can unmute yourself if you want to ask questions.
I just have. Thank you very much, Mohan. Brilliant as always. I wonder whether I could start the ball rolling. I'm actually interested in the first part of your lecture, which pointed out the difficulties in diagnosis. And looking at the lower and middle income countries and your role in education together with Afzal, I was wondering whether there should be some mileage in developing some kind of a symptom checklist that would help people diagnose it, because we know that in our neck of the woods, the problem is most people go to their GPs before coming to the specialist, and most of these conditions are treated in primary care. Do you have any views on this?
Sure, absolutely. Particularly in UK, we have a huge way to go educating the GPs. We've done a very good job in educating the GPs as regards treating major depressive disorder. Even in developed countries like UK and others, we have done a very bad job educating the GPs about picking up the hypomanic symptoms in particular. So it's a huge amount of education that needs to happen in high-income countries to start with. In low-income countries, the model is different. Professor Shahan Williams pointed out to me, many patients in Sri Lanka, he said to me at the back of my depression lecture, come to psychiatrists straight. Because the general practice is not as developed like in other countries, they say most of the psychiatrists see these patients, not so much GPs. But there are some pockets in Colombo at least, and Kandy and other places, good GPs must be picking up these patients, and they need to be taught to have those symptom checklists. And they are already available. We don't need to reinvent our wheel. Mood disorder questionnaire, it's not really a research questionnaire. It's just 13 simple questions. Even nurses or some other person can administer this. They are self-rated as well. Patients can be given this in the waiting room, and then the GP can go through it fast, or a psychiatrist can go through it fast. Similarly, hypomania symptom checklist by Yul Sanks is not that difficult, but MDQ is an easy 13-item self-rated questionnaire that can easily be used to pick up hypomanic symptoms that are needed for a diagnosis of bipolar 2.
Thank you very much, Mohan.
Thank you, Mohan, for another excellent lecture. Shehan here.
Hi. Have you seen any leopards? Have you seen any leopards?
Yes.
Oh, there are some photos.
Yes. So, yeah, you had to cover a lot of ground. So thank you for rushing through. You must be really tired. It was a marathon session. It was nice to see Afzal joining in too. It was a pleasure to have him. Any new drugs coming up, Mohan? I mean, we are still talking of old drugs, lithium, but what do you think of the place of even drugs like levetiracetam and so on, the newer anti-epileptics? Do you think they have a place?
Yeah, interesting question. All of the new anti-epileptics, we have started with others like gabapentin. I showed a slide showing that no guidelines recommend gabapentin. Topiramate, again, very weak studies as adjunctive treatment. It may help with weight loss, but it doesn't do anything for the core mood disorder. Levetiracetam, similarly, there are no positive studies really worth. It is not even mentioned, or any of the new anti-epileptics are not even mentioned in the CANMAT latest guidelines, even at third line. Then people talk about pramipexole. There's a lot of interest in pramipexole in bipolar depression. This is a D2, D3 neurotrophic agonist. As an adjunctive treatment, that might help. There's a lot of interest in modafinil to treat the anergia type of symptoms. There is some interest in selegiline, more in major depressive disorder than selective MAOI inhibitor than bipolar disorders. But interestingly, this is after a long time I kind of updated my bipolar presentation. And surprisingly, for about 4 years, I have not done this talk. So I had updated fairly comprehensively. I spent quite a lot of time. Surprisingly, there haven't been much by way of actual licensed medication, right? Only thing to me, from 2016, I stopped doing these talks. So in the last 4 years, what has changed? The sequel study, quetiapine lamotrigine study, is just telling us maybe the combination can be started from the word go, right? Except for some of these fancy stuff like gliptins and others, they're not licensed as such, even though some people are using it experimentally in non-diabetic bipolar patients, or obese, etc. There are no they are not for prime time. So apart from the drugs that are listed here, not a lot has changed. It's just that we are kind of trying to improve the diagnosis. We are making sure that some of these antidepressant mood stabilizers can be used earlier. The lurasidone carpracin studies are definitely helpful because for a long time we were stuck with quetiapine with all the side effects, whereas these have less metabolic side effects, less anticholinergic side effects, less antihistaminergic side effects. So to me, combinations like lurasidone carpracin with lithium or lamotrigine is a better combination. I will drop quetiapine completely. Some of the slides I showed you, even at 300 milligrams, the dropout rates were very high. So there are some better quality antipsychotics that are dopamine blockers that are now available that are useful. Of course, we are learning more about lithium's usefulness, even in acute depression, etc. Levels, its benefits as an anti-suicidal agent, but these have been known for some time. This is nothing new. And some of the practical stuff, having a mood stabilizer wherever possible in bipolar depression, diagnosing it properly, having a mood stabilizer to prevent switch rates, particularly in long term. You could get away with short-term treatments. And one of the practical points is if you are using it short-term and antidepressant that is necessary, after you have optimized your quetiapine and lamotrigine, if there are still symptoms of depression, then you add an antidepressant. But remember to tail it off earlier than you would for a major depressive disorder patient. So these are some practical implications we are highlighting more and more.
Mohan,
Yes.
can I ask one question?
Yeah. Sure, Afzal.
Mohan?
Yes, I can hear you. Hello?
Hello?
Yeah, we
I can
can.
hear you.
Yes. No, thank you very much. Thank you. Shihan, can I just ask one question?
Yes,
Yeah,
yes.
thank you, Mohan. I mean, it was always it is always refreshing to listen to you.
We have lost you.
Prof. Afzal, we may have to ask the question again. We can't hear you.
He's gone off completely. We'll take another question and we'll come back.
He's back.
Oh, he's back.
Okay. Prof. Afzal, you'll have to unmute yourself and ask it again. We didn't get you.
Okay, is it okay now?
It's better now, yeah.
Better.
Yeah, no. I'm only saying that thanks, Mohan, for a very informative talk. When we talk about the classification of bipolar, whether we start doing it bipolar 1, 1.5, 2, 2.5, I'm always puzzled that how can we can simplify this particular type of classification for use in a sort of by the general psychiatrist. It looks a bit more academic in many ways, but Mohan, I mean, with your experience, how can simplify these messages to people who are doing practices not in a very tertiary care hospitals?
Absolutely. That's a pertinent question. I addressed that in slide 21, so I'll refer to that. I only showed it for academic reasons. I made it very clear. I killed it straight away. It's not clinically useful at all. You're absolutely right in pointing out these kind of 1/2 and 2.5 and all that is totally unnecessary. Our focus, going back to Sherva's question and now your question, is to get people to make the distinction between what is a major depressive disorder and what is a bipolar disorder. That is our first task. By use of mood disorder questionnaire, hypomania symptom checklist, or any other checklist we might develop. And then a simple distinction between bipolar 1 and bipolar 2, because majority of the patients seen in Sri Lanka and world over are bipolar 2 patients. Of course, there'll be some patients with classic manic episodes and mixed states who will be bipolar 1. And then it's a matter of making that distinction and treating those effectively with mood stabilizers in line with we have discussed is what is important.
Yeah, thank you.
The rest were shown purely for academic reasons and, it's a complete waste of time. Unmute, Anton. Unmute. You're muted.
Can you hear me now?
I can hear you now.
Yeah, yeah. Comprehensive as usual. What I want to mention is, I came across this in epilepsy conferences, combining different anti-epileptic medication with different actions on different receptors, rational polytherapy instead of polypharmacy.
Yeah.
So I tend to use that, rational polytherapy.
Absolutely. Absolutely. I also mentioned the word rational evidence-based combination treatment, same as what you suggested, based on different mechanisms and everything. So rather than calling it polypharmacy, which is a pejorative term, we should use the word like rational polytherapy or rational evidence-based combination treatments. Like in disorders like diabetes, when the metformin as a first drug doesn't
They can buy more than one, yeah.
we'll add an SGLT2 inhibitor or a gliptin. When those two combinations don't work, they add insulin. It's the same principle in bipolar disorder with multiple genotypes.
Thank you. Yeah.
So, Shohan, as usual, I will send the PDF version of the presentation to you within an hour, so you can share with all those who have attended. Those who are in the UK can email me directly. Those from the UK who need an attendance certificate, if you email me, I'll send you one for your CPD purposes. Okay, so with the attendance certificate, I'll send the PDF version of this comprehensive presentation. I've spotted a couple of minor errors which I'll correct and repurpose it and send it to you. Shohan, when is the next lecture on dementias? My last of the series.
Yes, that will be on the 26th.
26th, yeah?
Yeah, Sunday the 26th.
Sure. So
Yeah,
what I try to do there is to first do a presentation. First part of it is on diagnosis of dementia, how to diagnose dementia properly. And the second part I'll look at a few areas like vascular cognitive impairments, Parkinson's disease dementias to include Lewy body dementia, because these are important dementias that are usually not picked up correctly, and look at one or two rare dementias, but I won't spend too much time on rare dementias because common things are common. So I'll make it practical and user-friendly. I need to work on it completely and put it together. So that'll be at 1:30 same time on the 26th of July.
Yes. Thank you so much for spending so much time, and we are so grateful. And it's been a really useful CPD series. We'll be sending you the official feedback soon. And we're delighted to have Prof. Afzal Javed joining us. Again, a great encouragement to all of us. And
I'm also delighted because we need to use his good offices and do similar things in other countries like our friends around Sri Lanka, like Nepal, Bangladesh, even some parts of India. Don't think that every place is it's a All India Institute of Medical Sciences. Not every place is a NIMANS. There are rural areas.
Mohan, we are working on that, and as you very rightly mentioned that I'm in the process of setting up a group that will probably continue doing not only in Asian countries, but at the same time, there are so many needs in some African and Latin American countries. So hopefully we will try to take up that challenge through the member societies from different areas. So get ready for getting more involved.
Give me another month to get in shape. I'm in reasonably good shape. I need to improve my lung capacity. Yeah, my lung capacity need to be improved. So I'll do some aerobic exercises and I'll be ready.
Yeah. I'm sure it's quite an effort. I mean, you are really.
I think we have the president-elect of the Sri Lankan College also in the audience. I think Dr. Gihan Abewardene. He'll be
hello.
I hope Gihan can. He'll be taking over the college from end of September. I think.
Okay. Where does Gihan work?
He works
in Kandy.
Kandy, yeah.
Okay.
He's in the audience, but his video is not there.
How is my friend Samudra? Is she in the audience?
I sent her the link. She wanted to come, but I'm not sure whether she's there.
She's a very busy person.
Okay.
But I keep in touch with her through WhatsApp.
Okay. Okay. Thank you again, Mohan. Looking forward to meeting you again on the 26th.
Certainly. Thank
Thank
you.
you everyone for joining.
Thank you.
Bye.
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 How is Yala? Yala is good.
Yes, getting crowded again. Lots
You're
of local
maintaining social distances with the animals.
with the animals, I think.
Did you see any leopards? Seriously.
Yes, seriously, yes.
Send me
They are
some pictures.
overwhelmed. I hope they don't get COVID because of so many people visiting them.
Yeah.
Yeah.
Okay, then.
Okay.
Thank you.
Thank you.
Bye.
Thank you very much, Pradhan.
Bye.